Okay, well, we're going to move to talking about surgery, and I'm going to talk about small bowel neuroendocrine tumors. Then Tom is going to talk about pancreas and liver tumors. So I'll just start out with the small bowel. You heard of these being called carcinoid tumors. Again, small bowel neuroendocrine tumors is probably a better name. It's a little more specific because sometimes we refer to carcinoid tumors as tumors from other sites as well. So one of the things that you may hear over and over again today is that the incidence of these tumors has increased over the last 4 decades. And for small bowel neuroendocrine tumors, that incidence has increased 6-fold over the last 4 decades. Now, when people come in with small bowel tumors, and those are mostly of the jejunum and ileum, those are 2 parts of the small intestine. There's also the duodenum, but that's a little bit of a separate classification, just based on its anatomy. About 29% of them are localized, and what that means is they're in the wall of the intestine only, and about 41% go to lymph nodes nearby. That's what we call regional. And about 30% go distant, which means to the liver, bone, or elsewhere. Now, in my practice, about 85% of tumors are in lymph nodes and about 77% are in liver, but that's because I see those kind of patients. That's my referral basis. Now, how long somebody might be projected to live depends upon the stage. And if the tumor is localized, people have a very good prognosis and can live on a median of 170 months. That means half the people live more than that, half the people live less than that. If it goes to lymph nodes, it reduces a little bit, but there's still very long-term survival. And when it's metastatic, then the survival is anywhere from 50 to 70 months, which for metastatic disease from other tumors would be a long time. So neuroendocrine tumors grow slowly. Even if they're metastatic, people can live for a long time. Now, small bowel primaries are the most common GI site of neuroendocrine tumors. The incidence is about 10 to 12 per million, and about 50% are multicentric. And what I mean by that is that there's more than one tumor in the small intestine, not just one. And they tend to be well differentiated, which means under the microscope they look pretty mellow instead of aggressive looking, which is what Jennifer touched on as high grade or poorly differentiated. They grow slowly, they're indolent, but they often present late. And what we mean by that is with liver metastases or bone metastases. A lot of times we see people because they got a CAT scan for some reason, it showed liver lesions, and that's how they presented. Some vague complaints, and they got a CAT scan, and all of a sudden it was metastatic. Now, we talked about carcinoid syndrome. Now, carcinoid syndrome is interesting, and we talked about serotonin being the culprit. There are other hormones that are made by tumors, and normally your liver will break down serotonin, okay? But if you have metastases to the liver, the serotonin gets released outside of the liver into the inferior vena cava, which takes it around your body, which then causes this syndrome. So people don't normally get it if they just have a tumor in the small intestine. It's usually metastatic. And as was mentioned earlier, flushing is very common, 94% of cases, diarrhea about 78%. We talked about the heart disease. This slide says 40%. I think it's more like 5%. It's not really quite as much as they used to say. And about 20% will have wheezing. And for those of you who have this, you may have noticed that certain things will bring it on. And those are called the 5 E's. Eating, epinephrine, adrenaline, emotion, ethanol, drinking, alcohol, and exercise. So pretty common if you have high levels of serotonin, you take a glass of wine, you may feel flushed, or people may notice that you've turned red. It's one of those 5 E's. Now, the workup of a patient that we would see with a small bowel neuroendocrine tumor would start with a history and physical exam. We would ask questions about, do you have intestinal cramping? Do you have pain? Do you have symptoms of flushing or diarrhea, et cetera? On physical exam, you might see abdominal distension. You might be able to feel a big liver. You might see that somebody's flushed. And then we have biochemical markers that we can test. We can test for serotonin, chromogranin, pancreastatin. Some people will argue whether those are of value or not. There's a big difference of opinion how important those markers are. We tend to follow them, but a lot of other people don't think they're that helpful, and they just add expense. Imaging What we mean by that is just getting CAT scans or MRIs. I prefer a CAT scan for a small bowel neuroendocrine tumor because I can often see the telltale sign of one, which is enlarged lymph nodes in the small bowel mesentery, those blood vessels that lead to the small intestine. But often the lesion itself is not seen because it can be very, very small, and it's kind of hidden in the wall of the intestine in most cases. You can also see liver metastases. But they also, previous speakers talked about MRI, which is really good to look at liver lesions, and DOTA PET scans are really good to assess the whole body for the burden of disease. And endoscopy is not very good for this. There are some special endoscopy techniques to look at the small intestine, but endoscopy looks pretty well at the stomach and the duodenum, and then the colon. But in between those two places, you have 15 feet of small intestine, and the scopes don't reach there very well. You can get to the very end of the small intestine, and sometimes people will be diagnosed with a tumor that way, but I would say the vast majority are not, and it's not really that useful. A typical patient with a small bowel neuroendocrine tumor that I would see would be like this person. This is a CAT scan, which is a transverse section through the abdomen, and the arrow shows kind of a lump in the small intestine. Now, this is not that common to see a lump, but next to it we see those little white dots, which are specks of calcium in a lymph node near the small intestine, and that is a little more frequent to see. If we look in the pelvis of this patient, we see what is a very thickened loop of small intestine. That arrow shows the thickness. If you look to the right where you see that black thing, that's a loop of small intestine too, with a very thin wall. This intestine looks kind of sick. And if you explore the patient, and I don't want to gross anybody out, but this is what your small intestine looks like in somebody's hands. I think those are my hands. And in this person, the bowel on the top is normal, but right underneath it you see that kind of pink and really big bowel. And I've marked with stitches 3 different tumors that I felt, but further down there's another tumor, and this tumor is that white thing right there with the big loop of intestine on the right side of it and the decompressed loop of intestine beyond it. And the big loop is basically the bowel getting distended as it tries to push the food through this blockage, and then it will give people abdominal pain. And the whiteness of the tumor right there is also a sign that the tumor can actually spill out into the abdominal cavity and form little implants, and that's what we call carcinomatosis. Now, these tumors tend to start in the small intestine, and this yellow is what we call the mesentery, which brings in the blood vessels to the intestine. The tumors tend to spread along these blood vessels into lymph nodes, and that's my depiction of what a lymph node looks like. And then what we do is we want to resect that loop of intestine plus those lymph nodes that may have tumor in them. Now, the operative steps for removing a tumor will often start with an incision in the abdomen, usually in the middle. And if we're going to have to do work on the liver at the same time, we'll extend it up until underneath the xiphoid, which is up here under your sternum. And if we have to debulk stuff in the pelvis, then we're going to have to extend that very low as well. But the critical element is once you are in the abdomen is to feel this 15 feet of small intestine. You've got to feel it with your fingers or else you're going to miss these lesions, because people will often have more than one, and these things can be very, very small sometimes. You can have a liver full of tumor and have a tumor that's the size of a pea. So it's very critical. This just shows us feeling the small intestine, and on closer view you see this little white pea-shaped thing. This is a small tumor, and this is what a typical tumor would look like. And this is in something called the Meckel's diverticulum, which is a little outpouching of the bowel. Now, the next thing we'll do is we'll divide the intestine. You can see, I wish we had a pointer, but we don't. You can see the division of the small intestine on the right, and on the left there's a division of the colon, and those fingers are palpating the lymph nodes and pulling them down, and we're going to divide the blood vessels right above those lymph nodes so that we get the tumor, which is in the small intestine under my hand there somewhere, and those lymph nodes. And then what we do is we hook the bowel back up again. We call that an anastomosis. We have lots of fancy words for stuff, so don't be intimidated. And then there's a hole that we close with another stapler, and then we kind of reapproximate the mesentery. Now, this whole thing about one tumor versus more than one tumor is shown on this slide. And this just shows we operate on over 100 patients with small bowel intestinal tumors, neuroendocrine tumors. And this shows at 0 is like where the small intestine starts, and 500 is 500 centimeters further on, which is about 15 feet, where it meets the colon. The vast majority concentrate at the end of the small intestine, and very few are kind of towards the beginning. But these were the patients down here that only had one tumor. The patients that had more than one tumor are shown here, and this is the span of those tumors shown in those 2 yellow dots. And you can see kind of in the middle there that one patient had 129 of these. But if you're not feeling very carefully, you're not going to find these things. And that's one reason why I'm not a big proponent of laparoscopic surgery for these tumors, because if you don't pull the bowel out and feel it with your fingers and you're using metal graspers, which some people do, you're not going to find these tumors. Now, fortunately, most people who do it laparoscopically will pull the bowel out and feel it with their fingers, but it's very important that that's done. This is showing, again, this is somebody who we did an open incision, not laparoscopically. We made very small incision, and you can see here that with the white dots and the black stitches, there are about 9 different tumors. There's an enlarged lymph node right here. Oh, thank you. There's an enlarged lymph node there, and this shows that anastomosis, where we're using the stapler to hook up the intestine again. And then after we do that, we put it back into the abdominal cavity, and this is a fairly small incision. And this is about the same size that you would have if you had a laparoscopic removal. So it can be done, but most of the time we're doing other things. We're doing debulking of liver metastases, and so the incision is not going to be small like that. We only do that when the tumor is either very small or whether there's a lot of liver disease that we have to debulk. We also generally will take out the gallbladder at the same time, and we do that when we think people are going to be on somatostatin analogs, because those cause gallstones. The gallbladder, if somebody gets embolization, which Dr. Sulin will talk about, sometimes some of those particles that are embolized can knock off the artery of the gallbladder and lead to its necrosis or death, and that could cause problems. But if you don't have your gallbladder removed at that initial surgery, studies have shown about a quarter of patients need to have it removed for symptoms later, so it's not the end of the world if you didn't have it removed, but we generally will just do it because we're already there. Now, the overall survival of patients is shown here. The patients in blue are small bowel neuroendocrine tumors, and in our series from several years ago, about 79% of people live 5 years, and about 57% of people live 10 years, but in our population, 93% had lymph node involvement and 81% had liver involvement. So these are generally pretty extensive disease, and patients can do very, very well with a multidisciplinary approach. Our approach to small bowel neuroendocrine tumors is to remove the primary, that means like where it started in the intestine, remove the lymph nodes, debulk peritoneal carcinomatosis, so if there are little nodules of tumors, we like to take those out. And then we remove the gallbladder. And then if there are liver metastases, if we can, we're going to try to reduce the volume of those. And Tom's going to be talking about that a little bit in a second. And then we treat people with somatostatin analogs if they have metastatic disease, like lanreotide or sandostatin LAR. And then when people progress, we'll treat them with PRRT or everolimus. So I'm going to introduce our next speaker, which is Tom Clancy, not the author of Hunt for Red October, I don't think, but actually an expert in neuroendocrine tumors, which is even better for you guys. And he's the co-director of the Pancreatic and Biliary Tumors Center here at Dana-Farber, Brigham and Women's Cancer Center, the associate chief of the Division of Surgical Oncology. And Tom's going to talk to you about pNETs and their metastases.
Thank you very much, Jim, and thank you very much to the New Neuroendocrine Tumor Research Foundation for inviting me to speak. It's really interesting at a conference yesterday to speak amongst like-minded professionals treating neuroendocrine tumors, but it's actually a very meaningful thing for providers to speak at and have an opportunity like this to address patients largely, an audience of largely patients who are affected by this. Thank you very much for the opportunity. I'm going to try to run through a few relatively big topics, starting with pancreatic neuroendocrine tumors. As has been mentioned, they're relatively rare, probably around 5 or 10% of all pancreatic tumors. Most are sporadic, sometimes associated with inherited cancer syndromes, and really have to be distinguished from pancreatic cancers. Most frequently, patients will be told they have a pancreatic neuroendocrine tumor, and it sounds just like pancreatic cancer, which is a really different prognosis and a different situation. But they can often be distinguished by imaging. So a pancreas cancer doesn't take up contrast as hypovascular and can look like pancreatitis. These look very different from something that really lights up on a CAT scan or MRI, such as a pancreatic neuroendocrine tumor or renal cell metastases. And I'll have a few examples of those later. They have a very diverse biology, as has been pointed out. Many of them will have metastasis at diagnosis, other than insulinoma, which tends to be fairly indolent. And overall survival can be really years, even in the setting of spread. With resected non-metastatic neuroendocrine tumors of the pancreas, long-term survival can be excellent. Really, there's a chance of cure. So most of these are non-functioning. There's no hormones produced, and there really would be no evidence of anything in the pancreas at all. The functioning are really distinguished by this production of some sort of hormones that causes systemic syndrome, which is really characteristic of the type of hormone that's being produced, either insulin or gastrin, or much less frequently glucagon, vasoactive intestinal peptide, or somatostatin. The gastrin and insulin-producing tumors are by far much more common. Surgery, as has been also pointed out, histology, the presence or absence of metastasis, and size and site of these are really the major determinants of how patients will do. Again, we can't emphasize enough that they can be relatively indolent with relatively prolonged survival, even in the setting of spread. And our goals of doing an operation are really twofold. Number one, we'd like to resect for some sort of oncologic benefit, to give a chance of cure or have a curative intent operation. And secondly, control a palliation of symptoms, because many of these in the patients who have tumors that are producing some sort of hormone, we would like to do an operation to try to minimize those effects. Briefly, in the functioning neuroendocrine tumors, insulinoma is by far the most common. Patients will present with low blood sugar, weight gain, what we call neuroglycopenic symptoms, or slurring of the speech and fainting and so forth, that are all relieved with carbohydrate intake. So these are really interesting, I think, because I'll always ask patients the same question. Say, where do you keep your snacks? And so women will always look into their purse and pull out something, a juice box or a granola bar or something. And the men who aren't carrying a purse will say they keep something in the glove compartment of their car. But they've learned, without knowing the diagnosis, that they become very symptomatic without constantly snacking. They gain weight not just because they're snacking, also because insulin, being a catabolic hormone, will cause fat storage. Gastrinoma, patients will have diffuse gastric ulcers and ulcer disease that's fairly difficult to control. And the others are much less common. Glucagonoma is one of these tumors that has a very interesting clinical syndrome. Patients present with very elevated blood sugars and a very characteristic rash, although honestly these are fairly less common. We probably, even in a high volume center, will see just a few glucagonomas and other tumors like this per year. The non-functioning neuroendocrine tumors are much less common, greater than 70%, but I think it's actually higher. Most, now with higher incidence of these diagnosed with better imaging, I think there's probably closer to 80 or 90% of the neuroendocrine tumors we see. There's been a dramatic increase in the small neuroendocrine tumors, probably with better imaging. If someone comes in and gets in a fender bender or goes to the emergency room for something, we're seeing so many incidental lesions of the pancreas and liver. And these, again, have a characteristic CT scan appearance where they're hypervascular. So this is a very common scenario. The patient who comes in with an incidental small lesion of the pancreas, and this right there, the hypervascular, just means compared to the rest of the pancreas, it's taking up contrast on a contrast-enhanced scan. It almost looks like what you would see in the kidney there. So we're using functional imaging more and more now with dotatate scans. As Dr. Chan pointed out, many of these tumors will have somatostatin receptors other than insulinomas, which have them in a much lower incidence. And we can exploit this in imaging to try to localize either the primary tumor or areas of spread. Triotide scan, which has been the stalwart of functional imaging for so long, now has largely been replaced by gallium-68 PET scans. And these dotatate scans will have an extremely high sensitivity, not just for metastases, but also can confirm sometimes the diagnosis without biopsy. So the one thing to be careful of is there's such a high degree of background uptake that it has to be really interpreted carefully. In a patient like this that we just saw, what we might do in the past is we'd have a high suspicion of a neuroendocrine tumor, but think about a biopsy. While biopsy sometimes is still used, uptake with a dotatate scan now might be confirmatory. This is a patient I saw just, I think 2 weeks ago, who has this tumor right here. He had a CT scan done for hematuria and found to have an incidental lesion in the pancreas. Well, we went back and saw that 10 years ago he had a CT scan done that was a small tumor that was unrecognized. It was probably only about 1 centimeter at that time. We suspected a neuroendocrine tumor, ordered a dotatate scan, and what you can see right here is really hot uptake right there at the tumor. There's a lot of other background that has to be interpreted carefully, but this was fairly confirmatory. In looking at all the other images in the scan, we were able to determine that there was no evidence of metastatic spread. So this is a patient who will now be a candidate for potentially curative surgery. The pancreas, as many of you may know, lies toward your back, runs across your abdomen. If you really were to put your hand right where we think of our solar plexus or right below your breastbone and push back, that's right where your pancreas is. And the head, the head of the pancreas, right around the small bowel, coming all the way to the tail near the spleen. These relationships are important just because when we talk about the types of operations that are necessary, it's really determined by the vascular and other anatomic relationships. So the head of the pancreas is really where a lot of action is. It shares the blood supply with the duodenum. The bile that goes right through there, and those relationships determine an operation that might need to be done with a tumor at the head of the pancreas. In the body and the tail, which is actually a fair amount of the bulk of the pancreas, there's really not as much going on in terms of anatomic relationships other than the relationship to the splenic artery and vein, which sometimes necessitate removal of the spleen during these operations. This is just the same picture we would see in a CAT scan, where the head, neck, body, and tail, and the spleen right there. So surgery is really the mainstay of therapy for localized tumors. Tumors of the pancreatic head, really on the right side, are treated with what we call a Whipple operation or pancreatic duodenectomy, just based on the relationship to the duodenum and the bile duct. Tumors in the body and the tail can just be treated with a distal or subtotal pancreatectomy, oftentimes using the spleen as well. You're removing the spleen as well and making sure we take out all those lymph nodes. Enucleation is a type of operation where we're just taking out the tumor itself without removing other pancreas tissue, and that's mostly reserved for insulinoma because of the low metastatic potential of those tumors. This is a picture of the Whipple operation. So because the pancreas head shares the blood supply with the duodenum, we're removing the pancreatic head as well as the bile duct that travels right through there. And they just have to make 3 new connections, one to the pancreas, the bile duct, and the stomach when we're done. So I often tell patients it takes a couple of hours to remove everything and then a couple of hours to put it all together. So it's a little longer operation. Operations at the tail, you're really just removing the end of the pancreas right there and sometimes the spleen. The nice thing there is it's very straightforward usually to do that in a minimally invasive manner, either laparoscopic or I prefer a robotic-assisted manner. I think patients out of the hospital faster, back to work, back to their normal life with fewer complications. For non-functional neuroendocrine tumors, so it's fairly straightforward that for larger tumors, those over 2 centimeters or just over an inch or so, we treat these like cancers, like adenocarcinomas, because we think they have a metastatic potential. So they're treated with a Whipple operation, distal pancreatectomy, what we consider to be a cancer operation, removing the tumor, surrounding tissue, and lymph nodes and so forth. It's also clear that for tumors less than 1 centimeter, many of these are completely indolent and can be treated with surveillance only. So I have a population of patients, several patients who have a small tumor at the pancreatic tail. They have near complete atrophy of the pancreatic tail. And we'll see a tiny lesion right involving the pancreatic duct at the body and tail junction. And that atrophy tells us that this tumor has been there for a long time. And we'll do surveillance scans for some time and see that it's completely stable, and there's really no need to take a patient like that to the operating room. The question is for patients who have tumors between 1 and 2 centimeters. So we see more and more of these tumors. This is a source of major disagreement in the pancreas community, whether we should resect or observe these patients. And there's a strong argument to observe many patients who have tumors between 1 and 2 centimeters. So there are some good short-term observational studies demonstrating that if we're doing regular surveillance scans, many of these patients won't progress, and as long as we're following them, we can operate on those who grow, and maybe we can spare these patients the morbidity of a pancreatic operation. It should be noted that pancreas surgery, though it's done safer and safer now, still has considerable risk of complications and morbidity. So it's nice if we can avoid those operations if we don't need to put patients through them. Well, others will argue that database studies show that when we look at patients who have undergone surgery for tumors between 1 and 2 centimeters, that up to 30% will have lymph node metastases. And these observational studies, while they're very good, they're also very short-term. So it does, I think, require a very individualized approach. I think when we have patients who have high risk factors for surgery and so forth, we might be inclined to follow them a little longer. If we have a young patient with a tumor, particularly if it's getting close to 2 centimeters or growing, we might adopt a more aggressive approach. So there's also, Dr. Shannon mentioned, and others mentioned more about systemic therapy. This is a patient I saw back in 2012. This is a tumor that measured about 12 centimeters in greatest dimension, and we consider this to be unresectable at the time because it involved a major artery there called the celiac artery. And in cuts of the CT scan that we don't show you, there was another artery to the liver that was completely encased by this. This is a picture looking right through the abdomen. Imagine you're laying on the patient's laying down. We're looking from the feet up, I should say. So this is a tumor right here. So unfortunately, we had to determine that was not a tumor we could operate on at that time. And the patient was given chemotherapy. And after about 6 months of capecitabine Temodar, we found that the tumor had shrunk considerably. Now it's about 8 centimeters in greatest dimension. The arteries that were concerned are no longer a concern. The operation was still difficult, but this is now 6.5 years ago. And it's very gratifying because we'll send the CT scans up now because he now lives in another state, but is really doing well and have a very high quality of life. Insulinoma, as I mentioned, denucleation. This is a 55-year-old gentleman presented with fainting, hypoglycemia, symptoms improved with carbohydrates, and so this was a candidate for enucleation. This was a patient who we operated on a little while ago who had a tumor that was in a tough location in the head of the pancreas near the pancreatic duct, so was not, I think at that time, we didn't have robotic surgery available, so we ended up doing him through an open approach. Enucleation is just removing part of the pancreas. It can really be preferred as long as the duct to the pancreas is not involved. We don't need to take the lymph nodes. We try to do these in a minimally invasive manner. In the past, when we couldn't find these lesions in the pancreatic tail, some surgeons would just remove the end of the pancreas, and we really don't do that anymore because we have much better better ability to localize them with MRI, CT, and endoscopic and intraoperative ultrasound. This is a patient who did require removal of part of the pancreas rather than enucleation because you can see this probe right here is in the pancreatic duct, and the tumor itself involved the pancreatic duct. So if we try to enucleate that patient can end up having a significant pancreatic leak, which just it's a fairly morbid thing to have happen to a patient, and they did fairly well with a pancreatic resection. Although most patients can have enucleation. This is the patient that I showed a CT scan of earlier, where we can this patient did have to have an open operation, but really just peel the tumor right off the pancreatic parenchyma without removing much normal pancreas. I prefer to do these in a minimally invasive manner now, and this is just a picture of laparoscopic removal. There's a nice video, but whenever I try to embed the videos, it doesn't seem to work. And the tumor's right there. We are able to robotically put a suture on them, and then just peel again right off the pancreas, and it's about a 1-hour operation that has a really dramatic improvement because we watch their blood sugars before or even in the recovery room before surgery, and they're really in the 50 or 60 range, and after surgery they're almost completely normal, if not a little high sometimes, based on the presence of counterregulatory hormones. Switching to neuroendocrine liver metastases, so spread of tumor to the liver. Goals of therapy, why would we operate on someone's liver? Why would we treat someone's liver with a variety of local therapies? And really it's for, number one, the goal of changing the course of disease, oncologic benefit, and also palliation, or helping with symptoms. Can we reset the clock? If we know that, in other words, that this is a disease that is not going to be cured, but somehow slow it down and allow a longer disease survival, or I should say, allow a longer survival even in the presence of disease. So control of liver disease is particularly important because many patients with advanced neuroendocrine tumors will have the liver disease as a primary source of morbidity and mortality. In a lot of ways we can do this. We can remove tumors, we can ablate tumors or burn them. You can use transarterial therapies, but more commonly we're using some sort of combinations of these modalities in order to treat the tumors. Surgery by far, there's no question, has the best reported outcomes. But the problem is that any of these studies are very, very highly selected. So we're not comparing the patients who get surgery sometimes have a much more favorable disease than patients who get other modalities. And it's really hard to do a head-to-head comparison. That said, there's no question that patients who can have surgery certainly have very good reported long-term outcomes. Tumor ablation in burning these tumors, either intraoperatively or under CAT scan or ultrasound, can be done, but that's particularly applicable for tumors that are, probably less than 3 or 4 tumors and under 3 centimeters in size. And transarterial therapy can be used in a wide range of tumors, but particularly in patients who don't have other local options available. Regardless, it should be noted that, recurrence is almost expected in these patients. That should not be taken as treatment failure. So patients who recur down the road, this doesn't mean that the treatment failed. We can often slow things down, and we don't mean that it doesn't mean that we failed in what we've tried to do. This is our study showing about 650 patients at Brigham and Dana-Farber, and essentially the top line shows long-term outcomes with surgery. And as I mentioned, that surgery patients who had some sort of hepatectomy for neuroendocrine liver metastases had long-term survival, certainly greater than 10 years. But of course, patients who had surgery had much different disease. So patients who had operations for two tiny liver tumors it's a different type of patient than someone who had diffuse spread. So it's very difficult to compare in a head-to-head manner. This is a common patient we would see, patient with a large tumor in the right liver, and we take out the right liver, we see considerable growth in the left liver, and this is about 5 years later with no evidence of recurrence, and this patient can come back to get new scans probably every 6 to 12 months. This is one of my favorite patients, someone I saw in 2009 who came in who had this mesenteric mass, and he had this tumor there. There were also 2 further tumors farther up in the right liver. This is before dotatate scanning, triotide scan, and we were able to suggest that this was the only disease limited in the liver. He had both operations done at the same time, did very well, comes back from upstate New York to get scans regularly, and really has had for a long time no evidence of recurrence. Our visits now are largely social. He's become a friend. He talks about politics and the Red Sox. And now we see that 10 years later, he has this right here. So this is about a 1 centimeter area of recurrence. This has been stable now for about 18 months. Right now, there's not much to do. So he's also sees one of our medical oncologists, and the question is when we start some somatostatin analog. And at current time, we're just observing these because they're very small, and there's no reason to think he won't continue to have these small lesions stable for some time. This is another patient who's actually I had known through other means before I met her as a patient. Had this very large mass in segment 4B or 5 of the liver, biopsy-proven metastatic small intestinal neuroendocrine tumor, and surgery had been considered. The patient was very, very reluctant to go surgery for a variety of reasons, and based on other things going on with her health and her life. And she was really unwilling to consider surgery, but this appeared to be a very isolated lesion. And this is probably now about 2 years ago. So we started to have dotatate scans available, and a dotatate scan was performed. It's not very well shown here, but we saw a very avid lesion right here in the liver, but there are also a number of other hot spots. She had, evidence of disease in the orbit, supraclavicular and other abdominal retroperitoneal lymph nodes in her bones, and based on that degree of spread, she decided that she did not want to undergo surgery, and she's still on therapy right now, but did not undergo liver resection. So just to wrap it up, I think it's clearly that surgery shows the best long-term outcomes of all the local region options for liver metastases. Although clearly, as I mentioned, these are very highly selected studies. Resectable disease means disease that we can remove while leaving enough healthy liver behind with limited or at least controlled disease outside the liver. And we can do this even if we have to stage the operations or combine resection and ablation. Recurrence is not a failure. Recurrence we expect because we know that there's a high degree of microscopic disease elsewhere in the liver. Symptomatic disease in particular may benefit from debulking even if we can't remove all of the liver. And there's also, as Dr. Howe mentioned, a role for debulking therapy, and this is a very hot area of debate. Can we help for patients when we're removing 70 or 90% of liver disease, even if we're not removing the entire tumor? And I think that's something of active discussion. If it can be done safely, I think is a reasonable consideration. This algorithm right here shows that in general, how we approach it. If we have no high-grade disease, which you mentioned, but in really limited or no extrahepatic disease, the primary tumor should be removed. In resectable disease, as I mentioned, just low-volume disease or unilobar or bilobar disease where we think we can get it all out, then we're really talking about surgical resection if possible, or a combination of ablation and resection, or sometimes transarterial therapy as an adjunct. Unresectable disease, that disease that can't be approached surgically. If the disease is symptomatic, we're really debulking if possible, otherwise looking at transarterial therapy. And I think I'm probably over time. Thank you.